Hi everybody. Back with the Module 2 lecture recording. Let's jump right into it. So, um, Today we are going to be talking about the normal growth patterns and determining which determinants of that pertain to the pediatric patient the most. We're going to be specifically talking about Erikson's developmental framework to understand things by age and stage. I'm also going to focus a bit on Piaget because it's kind of hard to understand one without the other. But your learning activity for this week is going to be based on Erikson's developmental framework. So that's why it's specified here. And then I have applied pediatric dosage calculation principles because we're going to only briefly talk about weight-based things in the pain management section. So just FYI. Okay, so growth and development. You've heard it a lot up to this point with me already. If you dig back in your brains, you had growth and development discussions in one of your prereq courses. It's usually like a lifespan psychology type course. And it truly is the bread and butter of pediatrics. And so keep that in mind as we move forward. Everything is going to be growth and developmentally based. So synonymous terms would be age and stage. That also refers to growth and development. I get sick of typing it out. So G/D, that's growth development. And the big points I want you to get across out of this lecture is how to tie it back into that health promotion piece that we talked about, how to tie it into your physical assessment concepts, because everything you do, literally from assessment to health education to triage, will be based on the age and stage or growth and development stage that the child is on. As I go through here, because I've seen a few emails that talk about blueprints being great for exams. Obviously, of course, if you have a layout of how many questions on which topic there are, makes it a little bit easy, sometimes too easy when you're studying. So one of the goals, an informal objective really, by the end of this lecture is for you to have a better idea of how the growth and development concepts will be applied on the exam as well. Okay, so let's start at the beginning. There are foundations of growth and development. There's two components here. So there's developmental tasks, and these are assessed by the developmental age. And this could also be termed things like milestones. You've probably heard that, especially those of you with kiddos, developmental milestones. Are they reaching their milestones? And then the direction of the physical growth. This is something that also falls under growth and development. So what that means are the terms cephalocaudal, proximodistal, and differentiation. So without making it super confusing or complex, think about a toddler, whether it's a toddler you've had, a toddler that you've seen on TV, and think about a newborn as well. Typically they have big old heads. Their trunk is bigger than the rest of their body, and then their little tiny baby legs and arms, they start small. And then by the time that they walk, everything has equaled out a little bit more. So we're going from the trunk and growing outwards. And that's the same thing, proximodistal. Break that down. What does that say? Proximal till distal. So trunk, head, these are growing, and then arms and legs. I know you can't see everywhere that I'm gesturing. And then differentiation, we're going to specifically address that as I move forward in some of these pieces. And so this is where you get the growth and development concept. So I talked about it a lot, developmental age periods. I do want you to note, if you're looking in different texts or pulling it up on Google, sometimes there is a slight discrepancy about the adolescent age period. So I've broken this down here by infancy, early childhood, middle childhood, and later childhood. And sometimes this end of middle childhood and beginning of later childhood can be the discrepancy. So sometimes you'll see 11, sometimes you'll see 12. Our book goes with 11. And so infants, you know, your new ones, your freshies, you've got newborns in there. And then this goes up to their first year, so birth to 12 months. Early childhood encompasses the toddler age group and the preschooler age group. So that's ages 1 to 6. Middle childhood, that's going to be your school age child from 6 to 11. And then later childhood, which is actually adolescence, 11 to 18. And so as we go through, again, thinking about assessment, thinking about how you interact with kids, thinking about the expectations of them, it all comes back to what developmental age period they're at. So when I say that, or you hear me say that, this is what I want you to be thinking. Which one of these buckets do they fall into at that point? Okay, so in keeping in line with talking about our foundations of growth and development, there are biologic determinants of growth and development. So 3 big buckets for you to be thinking about when we talk about growth and development. How tall are they? Their height, their weight, and their bone age / dentition. I'll tell you that we will focus more on the height and the weight than we will on bone age or dentition, but it is part of that. So I want you to have that full understanding. And so when I'm talking about height and how we're assessing growth and development, are they on track? Where do they fall percentile wise? The trends are more important for height than an individual data point. So what is their height doing over time versus what does their height look like today at a particular well child check? Now the weight, Now the weight is going to be more variable than the height. What are some reasons for this? There's a lot of them. Was the child down to a diaper? Was the diaper full? Was it a fresh, clean diaper? Are they wearing clothes? Are they wearing shoes? Was the weight taken at the end of the day versus the beginning of the day? And then there are other things like the calibration of a scale. Would we be talking about the same weight over a number of years at a clinic that uses the same scale and is always calibrated to the same amount? Or are we thinking about weights that are taken on different scales? And so that's why when we look at the weight, we expect a little bit more variability on the growth chart, and that's okay. But the height, we want to see less, and so therefore we expect to see less. And then a quick blurb about the bone age dentition. I think you've probably heard more about growth plates than these pieces. So bone age and growth plates. So if a kiddo breaks their arm or their wrist and they go in and they get x-rays, we're looking at the growth plates. Have they closed? Are they open? Where are they at? So when you look at that, when a trained person looks at that, they should be able to tell from looking at that type of scan roughly how old the child is. Same thing with the dentition. By looking at the teeth, we should be able to tell roughly how old a child is. And thinking about their teeth, we know roughly when baby teeth come in, when baby teeth fall out, and when the permanent teeth come in. Again, I'm not going to ask you to focus on those pieces because there's so much content in here. We've got to focus it in. I need you to understand the height and the weight components. And so by doing that, in order to do that, we talk about growth charts. And so you've seen me do this a couple times, and that's in reference to where do they plot on the growth chart. So let me see if this is going to let me take us to it. Yes, okay. Here we go. maybe. Okay, so this is the CDC growth chart from ages 2 to 20, and that's very important because plotting a kiddo on who's under 2 on a chart for kids 2 to 20 will make things look very different. So you have to be paying attention to that. So this is for boys, and so the way that this works is you find their age, you find their weight, you plunk it in there. Same thing for the height. And then we see over here, these are the percentiles. So if I've got a kiddo that's plotted on the 5th percentile, and he stayed there, he stayed there, he stayed there, and then suddenly we have a drop, that's a problem. What we see more likely because of the obesity epidemic is the weights are more up here by 95th and above percentile. And then here's where the height, so stature. And this is where I want to look at that trend. What's going on? Hopefully, in the ideal world, kiddos will plot all of their data points on the same percentilage, so we see a nice curve. But that's not truly realistic. It doesn't always happen that way. So what I need you to understand and why you're seeing this is just that this is how we look at heights and weights. Is it great to see it in a list? Yes, but in order to do some really good assessment, both nurses and providers will look at heights and weights on the growth chart. Okay, and then the bottom one was just for girls. Okay, so thinking about physiological changes that happen during growth and development of a pediatric patient, a couple big buckets here. So metabolism, temp, sleep and rest, and nutrition. These things change dependent upon the age and the stage. So metabolism, kiddos are going to have an increased BMR or basal metabolic rate the younger they are. Easy way to remember that, babies eat more often, right? They eat every couple hours. And then as kiddos get older and they get a little bit bigger, the metabolism slows down a smidge. Toddlers don't eat as much. And then when they have bigger growth spurts again as teenagers, their metabolism goes up and their caloric intake requirements go up. So on the outer edges of the spectrum of the pediatric age range, your youngest and then your teenagers as the oldest on the pediatric range, that's where that metabolism difference really is. So from your toddler to your upper end of the school age child remains pretty stable, but it will change again. Temperature, another big component of our physiological changes based on age and stage. Babies, and you should remember this because you just had OB, they have a hard time regulating their own temperatures at first, right? So the younger they are, the more challenging their thermoregulation is. And this is really tied into their metabolism. Sleep and rest. So the requirements for how much sleep a kiddo needs changes with their developmental age. Again, it's going to go back to your outliers. Your infants and your teenagers will typically need more rest than your kiddos in that middle age range. Why? Think about what we just said. Their metabolism is higher. They're going through this massive amount of growth spurts. You know, your kiddo, your infant through 12 months old is going through huge changes in their growth. And the adolescent, huge changes in their growth and in their hormonal states. So they need more sleep. And then nutrition, again, same thing. If you can correlate it back to my outliers, my infants and my teenagers are going through these big growth spurts, their metabolism is increased, so then they need an increased amount of nutrition to support that. However, with that being said, nutrition is the single most important influence on growth. And that's why we look at the trends on the chart. Because while our outliers, our infants and our teens, need more caloric intake because of their growth. Our kiddos in the middle, from toddlers to the upper end of the school age, they need steady nutrition and the right nutrition in order to support that stabilized growth instead of seeing the big spikes. And so these are important pieces. And I would encourage you to, when you're studying, break down the physiological pieces of this into these 4 kinds of buckets and thinking about, so if I have a teenager and I'm educating the patient and their parents about sleep and nutrition, because those are big components of our health promotion standpoint, right? What do I know about their bodies? What do I know about the age and the stage? And then how does that connect back to this topic? And so it's all this one big circle that feeds into each different thing to make this pretty picture of the growth and development. Okay. Okay, so I put this down as formal developmental assessment because ages and stages questionnaires are actual assessments that parents or primary caregivers will fill out about their kiddos. So if there's any parents in here with kiddos, which I know there's at least a few, depending on how old your kids are, you would have seen some version of this, especially if you have younger kids. This may actually look very familiar. And so when I say formal developmental assessment, now we're getting into talking about those milestones. And so under the milestones, there are these 5 components that we really focus on. We have the fine motor skills, gross motor skills, language development, social development, and their cognitive development. And so between these 2 ASQs, and that's how we abbreviate that because no one wants to say ages and stages questionnaires 9 times in a visit, this is how we assess for that. And so what's important here to note is that these ASQs are given to parents most often at well child checks. And so, kiddos are coming in their infancy through 12 months, roughly every 2 months, because we're wanting to make sure that everybody's on track. If you get off track on that growth and development spectrum early on, we want to do some things about it, and we're going to talk about that in a second. And then we continue to do these as their social and emotional pieces develop, as their cognitive pieces develop, and we're looking at all of these boxes. And so it's going to ask parents questions about walking and talking, and does baby follow you around in the room with their eyes? And these are all very important pieces. ASQs are also given out in home visiting programs. I coordinated a maternal infant child program back in Michigan, and our nurses and social workers who went out to see kiddos under the age of 1 who were Medicaid eligible, they did these in the home. And truly, that's the best place for this to be done, because that's where a kiddo is the most comfortable, where you're going to get the most accurate representation of what their capabilities are. And so that's why, thinking of the outpatient world, we ask parents and caregivers to try to fill these out before they come in, so that they can get a better assessment. Does it always happen that way? Absolutely not. And then you just do the best that you can as the nurse in getting these back from the parents. A lot of times they fill them out while they're waiting for the provider to come in. So what I want you to note is that milestones are important, but I'm not going to be asking you very simplistic questions like, at what age should a kid be able to build 8 blocks? This kind of information, this formal developmental assessment about their milestones, is going to be built in to complex questions. Because, example, if you're going to ask a child to help you with like a dressing change or a Band-Aid change, you have to be cognizant of their abilities to have fine motor skills and gross motor skills. So can they grasp the Band-Aid? Is there coordination there? Can they pull the pieces off without getting the pieces stuck together? Are they able to reach their whole arm forward and grab that away from you? So that's what I mean when I'm talking about these milestones and how to integrate it into your assessment and into your daily nursing work. And that's how it's going to be presented on exams. Okay, so while I'm not going to say at what age can a child do this, I'm going to expect you to know that information in a broad sense so that you have an understanding and can demonstrate that to me that you understand how growth and development plays into these different areas. And one thing that I want to mention too that I don't recall if I did or not, in your textbook, in the page number breakdowns that I've provided, please look at all of the tables that are in there. Tables and figures are fantastic study tools because it's already condensed all of the important information in most of those sections. And truly, when I'm looking at things and I want a quick reference, I go to the tables and figures as well. So instead of taking the time to figure out for yourself what you need to put into a table to resynthesize information, work smarter, not harder, and utilize what's in the textbook already. Okay? Because there's lots of them in chapter 9 and chapter 10 about all of these pieces. Like table 9.1 is about infancy and growth and development, and it has all of these components that I'm talking about all right there in one table. Okay. Let me check my notes here. Okay. So when we're talking about, I had mentioned we do well child checks about roughly every 2 months in that first year, give or take. Part of that is because, again, we want to make sure that the growth and development is on track early on, because early intervention is key. Just because a kiddo on like the ASQ, when it gets scored, so there's obviously doing really well, then there's this little gray area where it's like, you know, if they have some more activities and the families work with them at home, they should be able to get back into that doing really well spot. And then there's scores that are like in the black box, which there's a definite problem. These screening tools, these formal developmental assessment tools, are a great way to catch things early on. And so example of that I saw a lot in the clinic is kiddos who are being watched by grandparents or aunts and uncles at their houses versus kiddos at like a child development center. Sometimes, well, oftentimes, their fine motor skills are a little bit lagging because that's writing, drawing, coloring, learning that pincer grasp. And so if kiddos aren't being worked with at home or at daycare, you know, that's one of the common things to end up in that gray box, just because it's not happening a lot for them. And so early intervention can look like giving families developmental activities to work on and then reassessing at the next well child, to providing referrals to services. Oops, I've got to stop touching that. Providing referral services for professionals. So this is a quick screenshot of the Early Intervention Alaska Infant Learning Program, which is a phenomenal resource. And you can go there as a family member, you can go there as a medical provider. There's a spot for these guys to log in. And I have to say that despite the wide demographic spread, thanks to the geography of Alaska, we have a really great early intervention program both in Anchorage and in the Valley. And that's key because these kiddos can be a little bit behind or they can be way behind. And with enough intervention and rigorous services, they can catch back up by the time they start kindergarten or make it into 5th grade, etc., etc. Okay, so switching gears a little bit more. Now we're going to talk about the developmental theories and theorists. So there's three main ones: Freud, Erikson, and Piaget. Freud deals with the psychosexual. I just want you to know that he exists. Erik Erikson deals with the 5 stages of the psychosocial development. And Jean Piaget deals with the 4 phases or stages, however you want to phrase it, of cognitive development. I used to only have students really focus on Erikson, but found that it was just so hard to separate it, the cognitive development out of the psychosocial, because you truly do have to understand how kids are able to think and where they're at with that piece for all of this good communication and assessment that I've been talking about. And so Erik Erikson's got these 5 stages: trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, industry versus inferiority, and identity versus role confusion. Now, if you think back to those developmental ages and stages I talked about at the beginning, these go in order and they address each one. So infants are going to be working on trust versus mistrust. And so when you look in your learning activity and you see that I ask you to talk about the favorable outcome for Erikson's theories, I'm talking about these guys here on the far left. So trust, autonomy, initiative, industry, identity, all those really positive characteristics and qualities, the protective factors, that is the favorable outcome. If things are not happening for kiddos the way that they need to, and interventions and care provided by family and providers, etc., is not happening to support the favorable outcome, then the unfavorable outcome is what's here on the right. And so an example of this, trust versus mistrust in your infant, think it through. What is an infant doing when they cry? They're asking for their needs to be met. So in order to support the favorable outcome, what needs to happen for an infant? Their needs have to be met. Changing, feeding, sleeping, comfort, bonding, attachment, all of those pieces need to occur. Now, I have mentioned a few times that I work in mental health with teens, and about 90% of the kids that I take care of have ACE scores that are 5 or above, so they've experienced significant trauma early on in their lives, and that's where a lot of their behavioral issues stem from. And a lot of these kids, unfortunately, fall under the unfavorable outcome. So, for example, an infant who's not getting those needs met, they're not feeling secure in attachment with their provider or their caregiver, their family, they're not being fed, even though they don't have the understanding like a teenager would of that. Psychologically, the connections are happening, and so something that can develop when the unfavorable outcome occurs is reactive attachment disorder. These kiddos never develop a strong bond with their caregiver early on, and this sets the tone for a lot of really negative qualities for these kids to exhibit as they grow older. It's really sad, actually. Another example, autonomy versus shame and doubt. So if this was infant, now we're talking about our toddlers. And if anybody in here has ever worked with in a professional capacity or parented a toddler, or even just watched TV in the way that toddlers are portrayed, it's all about them, right? Toddlers are very egocentric. They will tell you no. They will tell you exactly how they feel in their limited vocabulary. But what we're trying to do in the developmental stage here based on Erikson is foster a sense of autonomy. So example of this would be, let's see, so kiddos have to wear shoes once they can walk, right, when we go outside. And we know as the parent or provider or caregiver that they have to wear shoes to be safe in most instances. But a toddler in order to foster that sense of autonomy and confidence, needs to still be able to exert that autonomy. So what do? You offer them choices. That's one strategy. So if the kiddo today has to wear shoes when we go outside to go to the store, you can wear the red rain boots or the blue gym shoes. And then they're getting that ability to choose, which fosters autonomy, builds their confidence, versus shame and doubt. That's the unfavorable outcome here. So if toddlers aren't offered the opportunity to grow and explore their world and feel confident and learn how to make decisions within boundaries, then they're going to develop a sense of shame or doubt, which it seems simple, but there's a lot of ways for that negative outcome to occur. Okay, so those are just some examples. Your learning activities will reinforce this week. And if, again, like it says in the assignment, please do a good job on these, because I'm going to put all of these slides together in a PowerPoint and get that posted in the module for you to use as a study tool for your exam. Now, changing gears a little bit and talking about Piaget stages of cognitive development. So we've got sensory motor, pre-operational, concrete operational, and formal operations. Without even looking down here at the ages, let's use some context clues. Sensory motor. Break that down. What is it? It's sensory and motor. Pre-operational, concrete operational, formal operations. So if you're going to break down sensory and motor, what do we know about sensory? That's touching, that's using our five senses. Motor is moving, grasping, doing things. So these kids are learning about their world and understand from a cognitive standpoint what they can see, hear, touch, and feel. That's how they're learning. That's how they respond. That's how they think. And that goes up to 2 years. That makes a lot of sense, right? Infants, they learn by touching and seeing, grasping. They put everything in their mouth, up to 2, and that covers our part of our toddler age, right? So again, toddlers want to put everything in their mouth. They're drooling. They're kind of gross sometimes in that way, but that's how they learn, and that's how they think. Now we get to pre-operational, and now we're looking at 2 to 7. So that's kind of a big age range, right? So pre-operational is going to cover this long-standing period where they are rapidly learning, rapidly growing, but there's a specific context to how they think. Then moving into concrete, so if you've ever worked with an 8 or a 9-year-old, the world is very black and white to them. They're not capable of abstract thinking yet, but they can understand very solid concepts. Formal operations is now where our teens and tweens are able to think in an abstract way. And so this cognitive development is really important to the nursing perspective and the nursing role, because you need to be able to speak and pose questions and gather your assessment information at a cognitive level that's appropriate. So you would not talk to a 7-year-old the same way that you would talk to a 15-year-old. And that's what I'm talking about. And so this cognitive development plays very much into the psychosocial, because the way that they think and understand plays into their emotions and the way that they interact with other people, both peers at their own age, adults, and then you as the professional. Now, the learning activity does not incorporate Piaget stuff specifically, but that's because, like I'm explaining, it's so intertwined that I didn't feel that it was necessary to make you do double the work. When you're already thinking about what are your nursing interventions going to be to support the favorable outcome of industry in this school-age kiddo? Well, if you're going to be putting together an intervention that requires talking to the kiddo, you're going to have to think about what cognitive stage they're at and how would you then speak to that child. Does that I hope that makes sense. Okay, so we're going to switch gears again. Now we're going to talk about pain management, which the slides on pain management are brief and so are the page numbers. But it's important enough that we're going to go over a few pieces of it. So one thing that you're not going to get to see in person, because you're not doing in-person clinicals, is the difference in the quantity of medications that kids are on compared to adults. So it's a stark difference going from a med-surg floor where some of our geriatric patients have bags upon bags of medications, and our kiddos, you know, if they're there for a surgery, they've probably got an antibiotic and some PRN pain meds, maybe a vitamin, maybe a couple supplements, at least a vitamin D, or an iron if they're anemic. And usually that's kind of it, because kids are typically healthy. Unless you're talking about a child with a chronic illness, and that's a little bit different. Or a kiddo who's there for like neonatal abstinence syndrome, so withdrawal. You know, that's going to look a little bit different too. But in general, your child that's coming into the hospital for an acute issue is typically pretty healthy and therefore doesn't have a lot of medications, including PRN pain meds compared to the adult. So really important, obviously, is our assessment when we're doing pain management. And so in kids, there are a few different pain scales. You know, 3-year-olds are not going to be able to tell you, because we know cognitively that they don't think like this. You know, tell me your pain from 0 to 10, 0 being no pain and 10 being the worst pain you've ever experienced. So I've got the ages listed here, and you'll notice that these ones overlap. Wong-Baker is going to be your youngest with the Oucher, so a 3-year-old can use both of these. And thinking about pain scales that you've seen, and thinking about what we were talking about a few slides ago with how kids think and what stage they're at, that's how you determine if they're developmentally appropriate in using these scales. Now, if a kiddo is developmentally behind cognitively, but they're 3.5, that's where you need to assess, are they going to be able to accurately use the Wong-Baker or the Oucher? And if not, there's some answers for that. Alternative scales that you can use, but these are the ones that I want you to focus on, because remember, in this part of the course, we're talking about the well child, for the most part. Obviously, you're talking about pain, there's going to be an issue, but we're thinking the healthy child that comes in with, I don't know, they're having an appendectomy. There's going to have to be pain control after the surgery. Otherwise, this child is mostly healthy and developmentally on track. On the exam, if your kid in the scenario is developmentally delayed, I will provide that information to you. Otherwise, you assume that all kiddos are developmentally appropriate. And like I was saying before about the tables, this chapter in the book has really nice in-depth tables that illustrate all of these pain rating scales. So we'd be remiss, as we're talking about children, especially in the world of the opioid epidemic, if we do not talk about the non-pharmacological modes of pain management. I cannot tell you how effective distraction is. If you've never seen it in person, I want to apologize now that this is another one of those things that in-person clinicals would have highlighted for you, because distraction does wonders if it's done appropriately. A lot of times in kids and even adults, truly, the biggest piece of the pain response is the apprehension of how bad it's going to be, the unknown. So obvious, a common thing that causes pain in kids is vaccines. And the older kids have that apprehension because they've had vaccines before. Your younger kiddo, especially the first timer who is 2 months old, they don't know that a vaccine hurts until it hurts. Your 4 or 5-year-old getting shots, they remember how much that one might have hurt in their thigh the last time. And so they see that needle and that apprehension and that fear kicks in. If you are able to provide distraction in an effective way, I have given vaccines and I've taken blood without any tears at all. My first nursing position, the pediatric floor that I worked on, all of the floor nurses, we were responsible for all blood draws and sticks for any kid under the age of 11. And so you'd be surprised at the difference in that distraction piece. And so how do you distract a kid? You build rapport with them first. You don't jump in with a needle and start poking people, right? You build rapport. You find out what they're interested in. You talk to them about things that are going on. You make eye contact. Keep their minds engaged on the conversation so that the only smallest little piece getting that pain receptor, is not at the forefront of what they're thinking about. The other piece, and relaxation ties into distraction, vaccines and shots, they hurt more when you're tense because then you have to inject the fluid into a tense muscle. So the arm is going to be less sore and the day after, and the actual administration of the injection will be less painful, and a noodle will loose arm or leg. So getting those muscles to relax. You can do that through distraction and guided imagery, because once everyone tenses and then they relax, it goes quicker, it's less painful, and the pain is much less. Cutaneous stimulation is not one that I see a lot in practice, either in inpatient or outpatient. I've also never worked in the PICU where there is a lot of pain, so I can't speak to that. So talk to your clinical instructors about, because they've both worked in the ICU components of PEDS, on what they've seen for cutaneous stimulation. There are child life specialists are fantastic at assisting in non-pharmacological pain management, usually through the use of distraction. So bubbles, toys, things that make noise, all of those distractors can be brought in for painful procedures and things like that. And if you're wondering what a child life specialist is, that's somebody who works on a pediatric floor, who provides a giant range of services, who is a huge resource. I'm not going to test you on a child life specialist, so I don't want to spend too much time talking about them, but if you are interested in PEDS, or if you've ever been in PEDS floor, they are the ones that have the game room with all the toys and the Xboxes and all of those things. But they're very well trained in growth and development and how to connect with kids at the appropriate age and stage that they're at. Okay, so pharmacological, obviously we're always going to want to encourage non-opioid use first. Any age kiddo can take Tylenol. You have to have a child that is 6 months or older to administer ibuprofen. That is very, very, very important. It's an important teaching component that we as the nurses and we as the providers will talk about over and over and over. It's weight-based, truly, even though you can look at the box and it tells you how many teaspoons, whatever. That's still weight-based. It's just not being calculated. So you've got 10 to 15 mg per kg for Tylenol and 5 to 10 mg per kg for ibuprofen. And if any of you, which I know some of you do, but if any of you actually do become pediatric nurses, you will get asked this question so much. How much Tylenol should I be giving my kiddo? How much ibuprofen should I be giving my kiddo? So that's something to tuck away in your pocket. When we're talking about opioids, morphine is typically the first line preferred. And as an outpatient, as a primary care provider, and I've been working, gosh, almost 2 years as a nurse practitioner. And then if you include my time in clinicals, we're at about 3 years, 3.5 years. I have only seen morphine or opioids, and it was morphine, prescribed one time. And I didn't prescribe that. I was a student, so my preceptor prescribed it, and it was a short, like 2-day course of morphine. Obviously, we try not to give our kiddos opioids, and we definitely avoid codeine within that. An example of a child or a diagnosis and situation that we would provide the opioid over the non-opioid, sickle cell, sorry, pregnancy brain for a second. Sickle cell. I worked on the south side of Chicago in a small community hospital where there was a very large black population, and we saw a lot of kiddos with sickle cell disease. And those pain crises are so painful for those guys. Distraction, you can try, but it's not really going to be the first thing that's going to work. You've got to get that pain medication on board to take the edge off, to then try to use some of those other techniques. And that's where something like an opioid would be your first line versus trying to do the non-pharm first. The book does list the regular, like this, your standard dosage. You don't need to know that for exams. I just want you to be aware of these concepts. Okay. Okay, so it says questions. You don't really have the opportunity to ask me questions right now because you're not live with me. But please feel free to send those questions. As you've seen at this point, my plan is to put together kind of a Friday wrap-up video that's maybe 5 or 10 minutes that addresses to the whole class repeat questions that I've gotten in emails, tidbits and tips that I've thought of over the week. And so if you send me your questions, I'm going to give you my answer. But if I'm getting the same question from a few people, I'm going to address that in the Friday wrap-up. Okay. A few other things real quick that I would like to show you when we're thinking about this growth and development stuff. There are a few YouTube videos that I think are really good as they just sum it up visually, which I think can help with some of the developmental theorist stuff. So this one from the Khan Academy is really good. And this one's a pretty good one to do. It gives you the explanations and such. I like this one, the Undergrad Med. They have a lot of good stuff. This one is really good. I'm a visual learner though, so seeing the charts and the graphs all put together and the way that they list it and simplify all of that down with both the theorist and the developmental milestones, I think is really great. And that is one of my biggest recommendations when studying the growth and development stuff. One, it's rote memorization. There's no good mnemonics for remembering some of this stuff. You just have to do it, apply it, think about it regularly. Again, I hope that I've stressed enough what the integration of the growth and development concepts are into the exam. You need to know those two main theorists and those stages and how they apply to the child and how you as the nurse will apply that in your work. The other thing, and I think I said it in the beginning, is, growth and development ties back into the health promotion stuff. It is the foundation and bread and the butter of everything that we do. So another example of that for your studying purposes, when you're organizing your information out of the textbook and you're like, how does this woman want me to understand this information. So let's think about our top priority, because I'm big on prioritization, and that's always safety and injury prevention. And if you remember from the first lecture, we talked about that being part of the anticipatory guidance. Even that is broken down by the age and the stage, because you're not going to tell the parent or the caregiver of the toddler a safety preventions for the later school age child, right? So everything that you're doing and providing is based on where their child is and will shortly be. And that's how you've got to think about these things, and that's how I'm going to pose questions to you on the exam, okay? Again, look at those tables. They synthesize the information in a great way. Very similarly to how and why I find these kind of videos to be helpful. Okay. I'm trying to think if there's anything else with growth and development. That's really the big components of it. Your first exam will have a significant component of this growth and development stuff in the way that I've been explaining it to you. How you as the nurse will utilize growth and development in your everyday tasks and assessments as the nurse. How you're going to educate families. How you're going to assess children. So I didn't have any slides about the physical assessment part of growth and development, because that should have all been reviewed in the reading. But you've got to know when you're assessing a child, not necessarily their vital signs, because that would be really tedious and arduous for you to have to memorize that. I do need you to know that they are different for age and stage, but I'm not going to ask you what the appropriate blood pressure is for an 8-year-old compared to like a 2-month-old. I will, however, go back to that height and weight thing that we talked about, right? So we spent a lot of time on those two pieces on that slide, and if you go in your book and you look at one of those great tables that's in the chapter, it breaks down really well how they grow. So at what age should their weight have doubled? At what age should their height or length have doubled? Those are the kinds of growth pieces that I want you to be aware of, because that's important. You as the nurse are going to get asked questions like that a lot, whether that's inpatient or outpatient. And as we are monitoring those trends on the growth chart, that's something that you have to know. So I hope at this point, with all my rambling, that you are able to see how all of these pieces are integrated into one and how it informs your clinical judgment, your critical thinking, your assessments, and then what you do with these kiddos, and how to prioritize things. So I will stop rambling. Email me with questions, and I will see you guys next week, or at the end of the week, with the Friday wrap-up. Have a good weekend. I'm recording this on Friday, so have a good week.